I'm going to stick to only hepatic Wilson's disease challenges in the diagnosis, and a treatment can be taken at some other date. Apart from the conventional tests that we usually do for Wilson's disease, that is Kayser-Ring, the ceruloplasmin, 24-hour urinary copper, liver biopsy, and especially hepatic parenchymal copper estimation, and the neuroradiological imaging. These are the conventional tests, and they're full of challenges. There are 3 additional tests. I may not say the new ones. Genetic studies is definitely not new, but it has now recently come up strongly, and it is also having some challenges. The other 2 are new, that is ATP7B peptide identification, and also to identify the exchangeable or the free copper. Relative exchangeable copper as well as exchangeable copper. This is also a new test. So quickly through Kayser-Fleischer Ring, we know we can see it at naked eye as well as slit lamp. This is the look, but what to do when you have a sick patient in the ICU, and especially you are very, very challenged when you have an ALF patient and he cannot sit up and do the get the slit lamp examination. So recently they have come up with a Keeler handheld slit lamp, but I have gone and looked it up myself. We went through for our department, we went through this, wanted to buy this for the department, but the handheld slit lamp are available, but they're not very easy to use, not even for the ophthalmologist. So it is still a little, we need some training on the handheld before we buy that. The second challenge that we see is that most of these patients who are sick and who have high bilirubin in Wilson's disease may also have something called as, you may not have Kayser-Fleischer Ring, which is usually brown in color, but may have something greenish yellow, which is actually a bilirubin ring. Most of you must have read about this. And the important point is that we need to differentiate between these 2 rings. So the bilirubin ring cannot be seen by naked eye. The site is always circumferential, whereas a Kayser ring may start from superior, then inferior, then circumferential. The color, like I told you, is different. Texture is more homogeneous, whereas the Kayser ring is granular. The layer of the cornea which is involved, as against the Kayser ring, which is there in the Descemet's membrane, this is there in the peripheral stroma. Relation to bilirubin level is that these bile pigment rings, these are usually disappearing after the bilirubin goes below 10, whereas it has no relation with Kayser ring. And the Kayser ring responds to the chelation therapy, whereas it is not applicable to the bile pigment. So we need to be sure that what we are seeing is a Kayser ring, not a bile pigment ring. The Kayser ring is further challenges. It is only present in 40 to 60% of hepatic Wilson's disease, 20 to 30% of the pre-symptomatic Wilson's disease, and it is present also in cholestatic liver diseases. And the absence of Kayser ring does not exclude diagnosis even in the neurological disease, where it is almost present in 95%. So these are the challenges that one has to face while going through the diagnosis of Wilson's disease. As far as ceruloplasmin, the next common important test, it's an acute phase reactant. We know it's very low in neonatal period. So you cannot do this test as a screening test in the infancy. You can only use this beyond 1 year of age. So this is another challenge that you face with serum ceruloplasmin if you have an early Wilson's disease to pick up. The 2 methods of measurement of ceruloplasmin, one is enzymatically done, that is copper dependent oxidase activity seen towards the specific substrate, and usually commonly what you see around us is the antibody dependent, that is radioimmunoassay, radioimmunodiffusion, and nephrometry. Possibly we are doing nephrometry in ILBS. So these are the enzymatically done as much more accurate than the antibody dependent assays, and they have also challenges to face, and which I'll just subsequently tell you. So normal level of ceruloplasmin again does not exclude the diagnosis of Wilson's disease. At a cutoff of ceruloplasmin of less than 14, the sensitivity and specificity is very good. But even at the cutoff of less than 20, specificity is 95%, sensitivity is 95%, specificity goes down. So if singularly used, ceruloplasmin itself has a very poor screening test value of only 6%. Limitations are that it may even be very high in acute inflammatory states, in adult hepatology, in pregnant females, those females using oral contraceptives or estrogen supplementation may cause falsely high levels. Also, like I told you, immunological assays do not discriminate between apo and holo ceruloplasmin, so may it also give very high levels of ceruloplasmin. Falsely low ceruloplasmin is seen in renal and enteric protein losing conditions, in end-stage liver disease, in malnutrition, aceruloplasminemia, and heterozygote carriers. All this is well known, and these cause the caveats in interpretation of the levels of ceruloplasmin. Urinary copper. Although 24-hour urinary copper excretion is well known to be measured, but the problem is of the collection, especially in children. You may have problems of complete collection. Also, the collection container, which is usually should be a plastic or an acid washed glass container. Not every container you can collect the urine in. Usually more than 100 is best. In untreated symptomatic patients, it is diagnostic, more than 100 microgram per day, but even more than 40 microgram per day may indicate Wilson's disease and requires further investigation. So that is another. And you can see that the urinary copper excretion more than 100 or less than 100 is seen even in 16 to 23% of patients of Wilson's disease, especially in children and asymptomatic. So you cannot rule out patients with less than 100. The caveats with urinary copper excretion is like I told you, complete collection is very important for exact quantification. The copper contamination because of the container, and in renal failure, it cannot be done. Falsely elevated copper in the urine has been seen in autoimmune hepatitis, in chronic active liver disease, cholestatic liver diseases, and acute hepatic failure of any origin, as well as heterozygotes. Penicillamine challenge, even not spending a slide on it, I would say that it's completely non-reliable, both in adults as well as in children. Adults, the RCTs available have been found to be ambiguous, and hence I will not spend much time on this. The penicillamine challenge test should not be used, it's obsolete. Serum copper, again, is not a test for the diagnosis. It's just a test to calculate the non-ceruloplasmin bound copper, and this also is used for the monitoring of the patient. I will subsequently tell you that if you have done the ceruloplasmin with the antibody test, then it comes falsely high, and it may give very low copper, very low NCC, and you may have NCC mostly in negative. So it's not something that you can depend upon. It's totally found to be unreliable. Liver biopsy should only be done, again and again, I would like to stress upon it. It is only done if the clinical signs and the non-invasive test could not conclude a final diagnosis and there is a suspicion of other liver pathologies, then you can do a liver biopsy. The problem with liver biopsy is that the initial stages of Wilson's disease, most copper is in the cytoplasm is bound to the metallothionein, and it is not histochemically detectable. Whereas in the later stages of the cirrhosis, the copper may be there, but it varies from nodule to nodule, and the distribution is very uneven to be able to depend on that for the diagnosis. So the absence of histochemically identifiable copper in the liver does not exclude Wilson's disease. Hence, I feel liver biopsy for just liver biopsy is not something that should be done. But yes, hepatic parenchymal copper concentration has a role to play. Although, again, with the caveat, useful cutoff values in a recent robust Chinese study was found to be 209 as against the 250 value that ASLD is considering. 250 microgram per gram dry weight of liver is what has found a good sensitivity. Here even 209 had a good sensitivity and specificity. So the cutoff levels is little doubtful. Underestimation can happen because of the sampling error. If in cirrhotic livers, in most of my patients here, we have not found the hepatic concentration to hepatic copper concentration to be very helpful with the diagnosis, because most of them are cirrhotics. And if they're cirrhotic, then their sampling error is bound to happen. And then this test has a very limited availability in the country. There's just one lab that I know in Mumbai which is doing this test. And again, I feel that this test is not really very helpful. Neuroimaging, yes, it would be helpful if it is present, but is found only in very minority, and rest of the images do not, imaging modalities do not help in the diagnosis. We go back to the Leipzig score, the good old Leipzig score, which was founded in a small town of Germany by a few experts of Wilson's disease. Later on, it was validated in a number of studies, and hence we can use Leipzig score and have a diagnosis confirmed if the score is more than 4. But yes, a score below 4 means that the diagnosis is either possible or very unlikely. The next is the AZLD guidelines, which we know that the CuEx ring, the ceruloplasmin, and the 24-hour urinary copper in various combinations has to be looked at. If these three are in there, that CuEx ring is present, the ceruloplasmin is less than 20, and the 24-hour urinary copper is more than 40, in that case, the diagnosis as per AZLD is confirmed. If the other three combinations are there, then you should go and do the copper quantification. If the copper quantification is more than 250 microgram, then again the diagnosis is confirmed. But if it is between 50 to 250, then you have to go through the genetic testing. Less than 50 means it is some other diagnosis. The problems with genetic studies is that there are about 500 mutations of ATP7B who has a location on chromosome 13. There is a carrier state of 1%. The commonest presentation of ATP7B is with missense mutations. Most patients are compound heterozygous, as you can see in this graph here, that the green part is the compound heterozygous, and this is the commonest this thing. But if you have a patient, an index patient with a confirmed mutation and a confirmed diagnosis, then his family can be screened with a haplotype analysis, only looking at that exon where the mutation exists. It makes life a little easier and interpretation easier. These are the various mutations present all over the world. In India itself, if you see North India, South India, East and West, we have various mutations, separate mutations more commonly present. So it's this thing is that it's very heterogeneous. The heterogeneity is a problem with the genetic studies. Other limitations, molecular defects outside the coding region and in adjacent intron and exon junctions, as well as deletions can still be missed, and identifying variants of unknown significance is a problem and a diagnostic dilemma. And as you can see that this is one study where the largest group was variants of unknown significance. And this has been classified by one database that is called the Varzome database. So this is one problem that you face with genetic studies. The interpretation is very difficult. But when you request for a mutational analysis, when will you do it? You should only do if the Leipzig score is between 1 to 3. For those who have more than 4, the diagnosis is established. The genetic analysis is just optional. It's especially helpful if you want to, screen the relatives of the index case. Then it helps, because if you know the mutation, you can easily screen the relatives of the index case. But if the Leipzig score is less than 1 to 3, then a genetics testing is mandatory. What in most of Europe is being done is that they first do look at the recurrent mutations with the help of a PCR, and also analyze the 21 exons and sequences, flanking the intron and exon bodies by the Sanger sequencing. If you find them to have a biallelic mutation there, then the diagnosis is confirmed again. But if you don't find that, then you are again left with either doing the hepatic copper, with doing the hepatic copper content, as well as going for the Sanger's sequencing and looking at complete Sanger sequencing of the promoter region, and the large deletion and duplications can be picked up by what is called as multiplex probe application. If this also does not help, then you have to go for a entire ATP7B sequencing, and then maybe have a diagnosis. But see, this is one study where they have looked at the family testing, and the problem here is very important to look at. See, this one patient here is a fulminant Wilson's disease patient, and he had this, he was homozygous, both his allele carried this mutation, G710. His real brother also carried the same mutation, but he is asymptomatic. Sorry. He is asymptomatic. Similarly, in this family, one of the patients was a compound heterozygote with two mutations. One is this and one is this. And he had cousins with similar mutations, or maybe little different mutations, but they were both asymptomatic. So the genotype-phenotype penetrance, or the genotype-phenotype correlation, is not very good. So you will not know how is the patient going to behave, even if you know the genotype of that patient. So what we need to know is to know the functional assay of this ATP7B in each of these genotypes to be able to predict how these patients are going to behave. So there are no functional assays as of now. Does the detection of homozygosity or compound homozygosity prove the presence of disease? That also we are not very sure about, but yes, subsequently I'm going to show you some data on that. Finding of only one ATP7B mutation in a patient, not a homozygote, not a compound, but just one variant. Does it mean asymptomatic heterozygosity, and how are they going to behave in future? That also is not known. There are several databases that have been prepared, but they are not very helpful because they need to have what is called as, they need to classify the variants before it is very useful to use these databases. In one such study, they tried to look at 8 patients of hemolytic anemia with ALF, looked at their genomes, genetic studies as against the other Wilson's disease. And what they found was that the nonsense variants, other than nonsense variant and frame shift variants, were more frequently found in those with ALF, both in homozygous status as well as in compound heterozygous. It was just 8 patients, so really not much to talk about. So finally, no clear genotype-phenotype correlation exists in Wilson's disease as of now. Protein truncating nonsense, all we can say is that the nonsense mutations, the frame shift mutations, the splice site variants have a significant functional and structural defect in the ATP7B protein and may be associated with very severe disease, early onset. Missense variants are usually late onset, less severe, and more seen in the neurological manifestations. So genetics testing is not mandatory, and it really sometimes is not very helpful also. You may just have it as an optional thing. Recently, in 2021, they have tried to look at the functional assay of the ATP7B. And what they did was that they looked at the ATP7B peptide analysis. It was important to look at the peptide analysis and not at ATP7B itself, because peptides are present in the plasma and they're unaffected by the liver dysfunction. So they looked at 2 peptides. One is the 1056 peptide of ATP7B and other was 887 peptide. So 216 Wilson's disease patients were picked up, 211 with genetic results, of which 143 had genetically confirmed results and 68 had genetically ambiguous results. So they took their dried blood spots, they enhanced it with antibody mediated mediation so that they could enhance the ATP7B peptides, and then they did the LCMS on this and tried to then identified the ATP7B, these 2 peptides that I just talked about. So what they found was that these peptides were very low in the normal control, were very high in the normal control, almost in the range of 200 to 300, whereas in Wilson's disease, they were below 50 or maybe in the range of 30s to 40s. ATP7B peptide that was deficient in 92% of all the Wilson's disease patients. In 94% of genetically ambiguous patients also, the peptide was low. In 91% of the genetically confirmed patients, the peptide was low. In 88% of these normal ceruloplasmin also had peptides low. So this is a very important advancement in the diagnosis of Wilson's disease as it appears now. As you can see that the concentration of the peptides, both 1056 and 887, both seems to be 200 to 300 in patients in normal controls, whereas in Wilson's disease patient, in homozygotes, in compound heterozygotes, and in carrier state, they seem to be low, especially so in these three groups, both the peptides. And these peptides was found, it was felt that the cutoff, normal cutoff of 200 to 300, or normal cutoff of 200 especially, and was having a very good ROC curve for both these peptides of almost 0.98. When you looked at these peptides in different genetic mutations, this is a very common mutation seen in the European Caucasians. So also this one and in this one, they were found to be very low in compound heterozygotes, as well as also in the homozygotes somewhere. Whereas here also it was very low, both the peptides. Whereas these two mutations, if you see, these two mutations seem to be having not that affected ATP, but although it appears to be affected, but not that affected as the others. Now the importance of finding the ATP7B peptides in these genetic mutations is very important. And to understand this, see, a homozygote may have both his alleles carrying maybe G71010S. Now, if he's carrying this on both, his levels may not be very affected. But if he's a heterozygote and carrying one this and the other one this, then his levels are going to be very less. So it places the homozygote may have higher ATP peptides than the heterozygotes, than the compound heterozygotes. If you look at both the peptides against each other on x-axis and y-axis, especially when you look at the lower level values of ATP, you find them in the lower values to be very much correlating with each other, even in those who are pathogenic and likely pathogenic genotypes. Even there they seem to be very, very correlating well and much below 100. Even in those with liver copper values more than 250, they seem to be below 100 and correlating well. Even when you look at values between 20 to 100, 10 to 20, you find them to be doing well in all over, as well as in those of variants of unknown significance also. They seem to be telling you that these cases could be Wilson's disease because they have very low both peptides present. In patients with liver copper less than 250, they seem to be doing well, but some of them have also been proven to be not Wilson's disease through this identification. Even those with values above 20, you do find that these patients are easily differentiating between those who are Wilson's disease and not. Even in those where the variants are not found at all, even in them no second variant is found, even then these could pick up the Wilson's disease patients. Especially here, this slide is this one's graph is important because if there was no ATP mutation and the liver copper was more than 250, they could show you clearly that all these three patients were not Wilson's disease. So it's easier to differentiate between Wilson's disease and not Wilson's disease with the help of these peptide identification. So the authors, which is the Wilson's disease group from US as well as Europe together, have come up with this algorithmic approach that you should do the Leipzig score. And if you find the Leipzig score more than 4, then your diagnosis is established. But if you find it below 4, in that case, you first do the ATP peptide analysis and you find the peptide analysis to be low, your diagnosis is again made. But if you find it a little higher, in that case, you do the mutation analysis. And if you find them to be having two variants, then your diagnosis is again made. But if you have one variant, with the help of if supposing you had one variant with this level of then possibly the diagnosis is made. But if you have one variant with this or this, then your diagnosis is not made, and you come in the carrier stage or in the unlikely diagnosis stage. And they could even take out the average amount of this peptide with the standard deviation. And of course, minus 3.55 is the place where you are confirmed diagnosis. Even minus 2.5 is confirmed diagnosis if you have at least one variant in the genotype present. So both genotype along with this ATP peptide 7B, ATP7B peptide identification may help out in future diagnosis of Wilson's disease and remove those challenges that we have been talking about. This is another place that I think we need to understand, that the free toxic copper determination is very important in these patients, because this free toxic copper is the one which is going to go from the liver, not being incorporated with the ceruloplasmin. It will go to the blood, and from the blood to the target organs. And this is what we need to look at when we are treating these patients. And even it helps in the diagnosis. Up till now, we were looking at the non-ceruloplasmin bound copper. Like I told you earlier, the non-ceruloplasmin bound copper is dependent upon the total copper minus the ceruloplasmin 3 times. Now, this usually is not very helpful. It gives you falsely low NCC because of the falsely high copper, falsely high ceruloplasmin that you see in these patients. So we thought of, there are now studies which can do the direct measurement of the unbound copper, and there have been various attempts, but now they can do what is called as exchangeable copper and relative exchangeable copper. This is done in 3 steps. You incubate it with the serum with a chelator, that is EDTA, and ultrafiltration of this is done with the help of certain filters. Direct measurement of this copper is then done in the ultrafiltrate with the help of a plasma immune diffusion. I'm forgetting the name of that thing. I think Jesse can help you, because we have already started one thesis topic of Dr. Aniket on this, where he's going to look at doing both the exchangeable copper and relative exchangeable copper. The relative exchangeable copper, as you can see here, in normal healthy patients, the relative exchangeable copper is the dark brown here, and it is just 3 to 8%. Whereas in Wilson's disease, it increases to almost 18.5%. So to detect this is important. The relative exchangeable copper helps you with the diagnosis, with the family screening, and with the differential diagnosis. As you can see here, the non-ceruloplasmin bound copper, whether you look at the controls or in the other Wilson's disease, you find them you find them not very different from each other, almost similar, the non-ceruloplasmin copper. So now if you look at the REC, that the relative exchangeable copper in Wilson's disease patient is much higher. In all other compounds, it was not that higher. Now, if you look at the family screening with the help of the relative exchange copper, both in heterozygotes and in those with no mutations, these levels were very low, whereas in Wilson's disease patient, it was high. So it's the only parameter which can discriminate between heterozygous and Wilson's disease. It's a practical and fast answer to the parents or to the siblings, and it avoids most invasive investigations. It is much more helpful than the other tests, that is total serum copper, ceruloplasmin. The closest that comes to the REC comes the urinary copper, but even urinary copper is not as good as the REC. As you can see, in Wilson's disease, it's very high. In other 2 groups, it is low. So the REC also helps, yes, it helps in differentiating between those with the heterozygous and no mutations. In the differential diagnosis, the REC also helps in the differential diagnosis. If you see, the first 2 groups are of the Wilson's disease, the other 2 groups are of that of the non-Wilson's disease hepatic in adult and in children, and they found to be very low. The RSE is very low, whereas in these both cases, it is high like it should be. So normal RSE that has been seen in all is 18.5, whereas it is very low in non-Wilson's disease hepatic copper. It's less than 18.5. RSE is normal in a variety of other chronic liver diseases of adults and children, as has been seen. You can see it is below 18.5 in both these graphs. The other part of REC is the exchangeable copper. This is exchangeable copper / total copper, whereas this is just exchangeable copper. And exchangeable copper, like the name it should explain to you, tells you about the extrahepatic severity of Wilson's disease. So if you have a hepatic group and you have an extrahepatic group, the exchangeable copper is going to be high in the extrahepatic group. Higher in patients with extrahepatic involvement, more than 2 micromole per liter, and it correlates well with the neurological signs. You should look for the neurological impairment in these patients. If it is high, copper diffusion in eye and brain is both seen. It doesn't correlate well with the hepatic severity, the exchangeable copper. The other place where it helps the exchangeable copper is the follow-up treated patients. If you see, these are the patients and non-compliant patients, and these are the compliant patients, whereas these are non-Wilson's disease patients. You see, the non-compliant and the new patients seem to be having a higher exchangeable copper than those who are compliant patients. So again, non-compliance can also be looked at with the help of the exchangeable copper. Finally, this one last paper that I'm going to tell you is the recent paper, which has just been, where they have used artificial intelligence, the Valentina Medici et al.'s paper, where they have used artificial intelligence to decide doing the LCMS in the CSF as well as in the blood, use the metabolites of Krebs cycle as well as urinary urea cycle defect, and they also looked at the conventional biomarkers. What they found was all those conventional biomarkers were not helping out with telling you the phenotype of these patients, but these, if you look at glutamate, and if glutamate is less than 0.068, then you have a control here. If the glutamate is higher and this ratio seems to be lower, then this is hepatic Wilson's disease. If you have a ratio higher, then in that case you look at the taurine. Taurine is going to be high in almost all Wilson's disease, but in some Wilson's disease, especially neurological, it may be lower. So I just forgotten which is this biomarker that they have looked at, but this is one what you call as the neural networking that they have done with the artificial intelligence, and it has a lot of validation to be done. So my key messages here are that the conventional tests have very many challenges. Genetic testing is optional, mandatory in those with inconclusive test. Genetic interpretation is very difficult. Genotype, phenotype correlation is not good. And the database variant classification is needed. ATP7B peptide identification and the algorithmic approach, I think, needs validation, although it has been done in a big cohort from various centers in US and in Europe. But I think it needs algorithmic validation in various geographical areas, even in India. The CEC, and that is the exchangeable copper, and the relative exchangeable copper are the most useful test which is available as of now, but not available in India, and they have been validated. Most labs should set up these tests. Only then we can go towards a better, better diagnostic Wilson's disease. As far as in ILBS data is concerned, the genetic data that I can present to you as of now, the patients, we do only 5 mutations. We have just kind of collected and decided 5 mutations, and we do them. We've done them in 141 patients with a median age of 9 years. And 92 of these 141 had positive mutations, 24 were homozygous, and 68 were compound heterozygous. And I think we have not taken up the single variants. with the help of Dr. Vipul and Shwetang Sharma, I'm presenting you, Dr. Shwetang Sharma, I'm presenting you this data in a slide here. The commonest mutation that we found was that of 3182, which is normally commonly seen in India, and the others are present here. I must acknowledge that I have used the ideas from Dr. Peter Ferenci's presentation, as well as from Nauza and from Kalpana Panda. I've used some of these slides in my presentation today. Thank you.